Andrea, if you want to do your opening announcement, I'd appreciate it.
Sure thing. Just a reminder to everybody that this meeting is being recorded, and I do my best to post up the recording of this meeting to the DHHR's YouTube channel as soon as I can after the meeting. And all media who are present on this call, if you could just hold your questions till the end of this meeting, and then we'll open up the floor for you to ask. That's all for me.
Thanks so much, Andrea. And I'll ask if you could post the agenda one more time for some latecomers to the meeting.
Sure thing.
Thank you so much. And we'll start this afternoon's meeting like we normally do with a quick epi update from myself. For those of you who don't know me, my name is Shannon McBee. I'm the state epidemiologist with the West Virginia Bureau for Public Health. And this is our HIV Taskforce meeting, HIV outbreak in Kanawha County associated with injection drug use. So since we last met in October, seems like forever ago, there's been 6 new HIV diagnoses. The diagnosis dates of the 6 cases that we've identified have actually been spread out throughout the course of the year. 1 diagnosed in Q1, 2 diagnosed in Q2, 1 diagnosed in Q3, and then the last 2 diagnosed in the Q4. Currently, 37 out of the 47 cases diagnosed in 2021 in Kanawha County have been confirmed to be associated with injection drug use. And just as a reminder, the data represented here on this graph shows residents of Kanawha County or individuals who were homeless in Kanawha County at the time of their HIV diagnosis. And so we've been getting starting to get some questions if, we're starting to see things trend downward in terms of the HIV outbreak here in Kanawha County, and just some things to keep in mind about case counts and just HIV outbreaks in general. So there's several factors that contribute to the fluctuation in case numbers. And so you can look at this graph and you can say, hey, we're trending in the right direction. Are we starting to see things turn around? But there are reporting delays. It does take time to locate individuals and then interview these individuals and then obtain risk factor information on these individuals to associate them with the outbreak. Although the last 2 quarters you see, we have seen declines in numbers of new cases identified. As I've previously mentioned, there are reporting delays. We've also seen some declines in testing events due to the weather, and also that pesky little thing that keeps reminding us all that we're in a pandemic still, COVID-19. So, it's too soon to draw any type of conclusions at this point from the decreases that we observed. We'll continue to monitor it. We also know that as the weather continues to get colder, that clients do not come out. It becomes difficult to find individuals, and they just don't come out for testing and other services available in the community.
Shannon?
Yes.
Are you sharing your slide or your screen? It's not visible at this time.
Oh, well, that's problematic. Yeah, I thought I was, but let's try to do that again. I even got on early to share my slides. Let's try that again. You could have peeped up a little quicker than that. Can you see my slides now?
We can.
Okay, good. All right, so I'll let you guys digest this slide for just a second. So you can see the slight decline in the 3rd and 4th quarter. 6 new cases diagnosed since we met in October. They've been spread out throughout 2021. 37 of the 47 cases identified in 2021 have been IDU. Next, looking at the epidemiology of HIV cases in Kanawha County since January 1st, 2019, there have been a total of 91 newly diagnosed cases of HIV associated with injection drug use that have been reported in Kanawha County. There's really been no real shift in terms of the epidemiology of the outbreak. At this point, there's still slightly more males than females. 80% of the cases are between the ages of 20 to 40 years of age. Nearly 50% of the cases are reported as being homeless or unstably housed in the past 12 months. We've seen a slight increase in the number of individuals who are co-infected with hepatitis C, but this is likely due to, increased testing and complete risk factor information, but 91% are co-infected with hepatitis C. And hospitals remain the setting where the largest number of cases have been identified at 46%. Next, looking at medical status of the Kanawha County outbreak cases. Most categories are trending in a positive direction, which is great news. Of note, there is an increase of 6 individuals ever linked to care since October. An increase of 3 individuals linked to care within the past 30 days of diagnosis. A decrease in the number of individuals with no evidence of care, and the number of individuals virally suppressed at last test, which is really our ultimate goal. We saw an increase of 2, bringing our total to 27 individuals. And then just a reminder, we do have our statewide data posted on our website by county, on our HIV Aware West Virginia website. There is a tab specifically for the Kanawha County HIV outbreak, and then we also post, Andrea, I believe, recording of this meeting on the website as well. Let's see here. And that is my update for today. One blank. All right. So I did invite a couple of guests this afternoon to give an update on the Syringe service programs across West Virginia. I've got Elizabeth Coffey with the Bureau for Behavioral Health and Joe Linmar with the Office of the Inspector General. Ladies, I don't know who wants to go first.
I can go first if you want.
Okay. Thanks, Elizabeth.
Okay. So we have 9 harm reduction programs that are currently in the process or being funded by the Bureau for Behavioral Health. Of those 9, 4 are fully licensed, and the others are in the process of being licensed. We also, just this week, or it was late last week, we're notified that SAMHSA was releasing a harm reduction grant, which is not SOAR funds, but because of our mechanism regarding grant process, we are the lead organization to apply for that. We did decide to apply for that funding. We're working with Deb Keister from Marshall regarding that. We have 2 harm reduction clinics that are interested in restarting that said that they were not going to start. And so 2 of those the money would go to funding 5 harm reduction clinics, 3 of those which would be new, and 2 would be reestablishment of closed harm reduction programs. If we get that funding approved, I'm sorry. If we get that funding approved, it's $400,000 for 3 years. So that would be $1.2 million. And so that would bring us up to 14 harm reduction programs. The harm reduction, there's some harm reduction act that is currently being looked at, which West Virginia would not be in compliance with the Harm Reduction Act because it allows for no, it's not restricted for one exchange. So when we're writing the grant, we have to address that issue. Any other, I mean, that's all the update I have. Does anybody have any questions? I will say regarding TA that Deb Keister, regarding the licensure process, is working with all but 2 of the agencies. And those 2 agencies are doing the licensure on their own. And we're handling the grants portion of the grants.
So technical assistance is available to programs through collaboration with Marshall University.
Yes, and for example, one of the most recently funded ones, they've already been licensed because of the technical assistance. So they've actually done really well. So right now we're funding all harm reduction programs that expressed a desire to be funded. There were no harm reduction programs that we turned away. And they're all funded at the amount that they requested. The new grant does allow for the purchase of syringes with the money, whereas the SOAR grant does not allow for that.
And I thought I saw Jolyn somewhere. She disappeared. There you are. Hey, Jolyn. Jolyn is with our Office of Inspector General, who has taken over the syringe service programs, the licensure. You want to give an update from your perspective?
Sure.
Thanks.
Good afternoon. As Shannon said, my name is Jolyn Mara, and I'm the Director of the Office of Health Facility Licensure and Certification. We're commonly referred to as OFLAC, and we're part of the Department of Health and Human Resources under the Office of Inspector General. And we have been assigned legislatively the new Syringe Services Program statute and now subsequent legislative rule. So it is a new program for OFLAC. We've been working with the programs so that we could educate ourselves as well as helping the programs work towards licensure. So currently, the way the statute was written, it stated that all syringe services programs that offered a full array of harm reduction services had to be licensed by January 1st, 2022 in order to keep operating. And then any new program could submit a license after January 1st of 2022, and the full array of harm reduction services as defined in the statute and legislative rule had to be offered. So to date, this is may actually have a couple more than Elizabeth referred to, but we have 9 syringe services programs in West Virginia that are licensed. They have completed the application process with OFLAC and have received a license. We have 2 more applications that are in various stages of being licensed. And we are working really hard with those programs, as we did with the 9 other programs, so that they can be licensed by January 1st, 2022. Our website at OFLAC has been updated. It's ohflac.wvdhhr.org. It has a link to the statute, to the rule, to the application, some frequently asked questions, and some other helpful information. We've also created a form that we've sent out to any known program that was a checklist to assist them with the application process, because the way syringe services works is there's not currently a required survey, an initial survey for a facility to be licensed. OFLAC only enters into a syringe services program unless we receive an investigation or a complaint, and then we would do an investigation. So the initial survey becomes very important because it's basically the application. So the application requires some very detailed information, including all the policies and such to be submitted with the application. Our program manager here at OFLAC, who is assisting, who is over the syringe services program, her name is Kelly Cooper, and her assistant is Lisa Lucas. So those of you programs out there, I'm sure you've worked with Kelly and Lisa, and I hope you find them very helpful. We are doing our best to try to ease into this and show folks that, you know, there is a lot of paperwork involved in submitting the application. But if you go through that checklist, and if you have questions about what kind of information is needed or what we are looking for, it's really reach out to us. We'll work with you to try to explain this to you. We understand it's a new program, and we're used to it, OFLAC here, starting some new programs. So we know that there's a little bit of a learning curve for all of us. If anyone is interested in seeing the programs that are licensed, this information is also available on our website. If you go to Health Facility Search, you can search for syringe services programs, and it'll show any program that's fully licensed. It does not show those that are in the process. It's only updated once the program is fully licensed. With that being said, if anyone has any questions about the application process and such, I certainly would be happy to take those and do my best to answer you or to get answers to your questions. Or I may have silenced the crowd.
Any questions for Jolynn or Elizabeth?
Well, I want to thank you all for inviting me to the meeting. I'm going to stick around for a few minutes, and then I have another meeting at 12:30. So if anyone does have any questions, you can always email, call our office, call me, and we try to be very responsive to try to assist folks.
Thank you both. Appreciate the updates. All right, we'll go ahead and move through our agenda to our partner updates. I see Dr. Young on the phone or on the Zoom, I guess you could say. And I know your time is pretty precious, and I haven't had a chance to speak with you, so I want to make sure that you have the floor to give any updates that you have from, I guess, both CAMC or Kanawha Charleston standpoint?
Thank you, Shannon. It's good to see you too. And I had on my agenda to share with you the social media posts that we have where we're going to be doing some indoor testing. We feel like we're going to be doing it in a safe enough location, providing COVID vaccines and boosters, as well as doing HIV testing and naloxone training. We're going to be at the Booker T. Washington Center in London, West Virginia on this Thursday. We will be providing incentives, and this is a partnership, of course, with University of Charleston School of Pharmacy, of course, our friends at Ryan White and Health Right, and our, going into the community to do this again, and again, the Ambulance Authority. So really putting a few things together to get the HIV testing back up and going. We did see a couple of indicators coming from the Division of STD that possibly not necessarily that location, but very close by. We have seen some numbers in other STIs with an uptick that may indicate an early, a reason to be concerned. So that's why we will be going into those areas. We'll be planning some additional testing and vaccination events, kind of co-branding, and doing those in the Rand area, and then of course Montgomery. We'll be working with a new recovery place. I'm sorry, which group? The Veltex. I'm sorry, I don't do that name justice, but we'll be working with the recovery group called Veltex to connect them to the eastern end of the county as well, because they cover the eastern end of Kanawha County for services, as well as Fayette County. So some joint adventures going on there. Of course, we appreciate all of our partners who are helping get us through this. We'll continue to do the testing. We'll be more indoors for the next few months until we can get out and do more testing events as we were before in outside and in the spring. So we'll look at opportunities as well as warming centers and other places become available as opportunities, not only for COVID vaccination, but also for HIV testing, and trying to keep those incentives going so that we can entice those to be tested. Also continuing to work, we're trying to make some connections for education for our first responders. I think that's coming from the CDC Foundation, and a connection through Amtech that's specifically geared for our first responders. So we're working not only with the city of Charleston, but Kanawha County to get that up and going. Also looking at implementation of HIV testing for our QRTs and seeing how we can bolster our QRTs in Kanawha County to better address the needs for our PUD populations as well. Looking at certain things we can do within the hospital systems. Again, I'm speaking as a health officer, not for CAMC, but I do see some of our partners on here looking at some sensitivity training and some things that we can do to make patient experiences a little bit easier, as well as how can we take the testing piece for HIV in emergency rooms and make that work. Really would love to go bigger with that, not just the testing piece, but connecting people to other therapies and making sure that they're getting the behavioral health needs met, as well as their medical needs met at the same time. So with that, that's all I have for right now. And thank you for having me on. And Shannon, I will send you that graphic to be shared.
Great. Thank you so much. Any questions for Dr. Young? All right. Suzanne Wilson with our division director for HIV. I know you've got a program update for us.
Sure, thank you. As Dr. Young mentioned, we are continuing our focus on testing and outreach, and working and supporting our Kanawha Charleston and many of our other community partners to look at ways to provide testing in non-traditional venues throughout the winter in COVID-19 safe environments until, as Dr. Young said, so we can get back outside and and do testing. We're really working to try to support these partners to keep testing available throughout the winter when it's more difficult to reach folks. Another one of our big focuses has been on training. And Dr. Young mentioned briefly too, we have partnered with the Mid-Atlantic AIDS Educational Training Center that's located in Morgantown to offer a series of virtual trainings around HIV and dealing with at-risk populations. The trainings there's a variety of topics covered, including compassion fatigue, for those working with at-risk populations, HIV basics, it covers stigma reduction, HIV testing and pre-exposure prophylaxis, and primary care of a person with HIV. The sessions are offered multiple times throughout the next few months to provide the most opportunities for attendance, and we've the schedule is varied different times throughout the day, trying to make things available at different times to hopefully catch people at different, with different schedules. There are audience specific tracks, and the materials are tailored for each group. Dr. Young mentioned one. We do have the first sessions that are getting started are for first responders. We also have sessions scheduled for medication for opioid use disorder treatment providers and inpatient clinics, a session for, or a series for healthcare providers and outpatient clinics, FQHCs, and then a series for emergency departments as well. And so a lot of the topics, the material for each topic will be tailored for, those particular groups. The information for these trainings is available on our HIV Aware West Virginia website under the upcoming training section. And there's also a link to the Mid-Atlantic AIDS Educational Training Center website, where there's also additional information. You can see the full schedule and the full complement of the trainings being offered, as well as information on continuing education credits that are being provided for all of the sessions as well. And we, I think that's our big updates for now. We're also currently working on, as it gets close to the end of the year, our surveillance program is working on data quality assessments and data cleanups, and so some of that stuff that affects some of the fluctuations in numbers that Shannon mentioned at the beginning.
Thanks, Suzanne. Any questions for Suzanne? All right. Christine Teague from the Ryan White program, do you have an update for us? So you got a room full of people.
Not sure where the microphone is.
Oh, there you are. We hear you.
Okay.
We can. Yep.
Okay. Yeah, we have my whole team is here today. We're getting ready to have our Christmas party immediately after this meeting. So we're all here today, which I think is good for our group to hear what's going on regardless. I'm glad that you're all here. Just to kind of give you an update on what we're doing. Obviously, we're the primary HIV provider in the area. And as such, we're focused on finding, linking, engaging, retaining, prescribing medicines, and getting people to an overall state of viral suppression. And just kind of a bird's eye view from the Ryan White program for the cluster, we know that there's 91 people in that group. From our standpoint, probably close to 50 to 75% of these people are unstably housed. 7 have died. 3 due to suspected overdose, 1 due to complications of endocarditis in hospital at the time of their diagnosis. 1 died in the hospital of intracranial hemorrhage, likely due to illicit substance use. 1 died in hospice from medical comorbidities, never left the hospital after their diagnosis, and 1 was the victim of a homicide. 4 are currently incarcerated that we know of. 3 are out of county in rehab that we know of. One is being seen by another ID provider here at CMC, which leaves 76 people sort of on our list that we're working with. And of that group, 22 of them we've not had any contact with. Either we've not been referred, those patients have not been officially referred to us, or those are the people that we've just not been able to find or engage in any way, which leaves 54 that we have had an encounter with, either in clinic or on our mobile unit that we take out 2 afternoons per week in Canal City or on the west side. 54 of those people, or actually 24 of those people, have been prescribed meds and are undetectable. So when I was looking at this data, one positive way to look at it is for the people that we've actually engaged with, that we know of, that we've had interactions with, about half of them are virally suppressed. So I think that is good news. We continue to be very engaged, obviously, in finding people and linking them. And Brooke Parker is here with me today. She's been the primary person out in the field that has been doing that work. And I wanted to ask her to also kind of give you an update from her standpoint on the things that she's been doing and kind of challenges and where we are with that.
Okay, so it's because I work primarily in the field with people, I've got, since October, 112 attempts to link care to 39 of these known people or lost to care. Because so much of our linkage to HIV care depends on them being stabilized and their basic needs being met. So when I look at our numbers for the last 6 months, we've had 18 housed and on meds. 8 of those people are on MAT, and 4 of those successfully completed their valve replacement surgery in the hospital for endocarditis, and they've been receiving care for other complications like osteomyelitis, sepsis, like everything else that comes along with IV drug use. We have dental services provided to 6 of those people, so that's full extractions and dentures provided by Ryan White, and working from the contact list provided to us from the CDC when they were here during the summer. We've tested, I counted 4 of that high risk list that just hadn't been tested at all yet or hadn't been found. 10 of that 18 are still unhoused, and they're working on the process of getting housed, but they are on meds. They are successfully, for the most part, staying on their medication and routinely coming to appointments. So because HIV care isn't accessible or sustainable if those basic needs aren't met, linkage to care now includes ongoing case management and discharge planning. For other health issues, primary care linkage referrals, and transportation to all the related services, including crisis intervention, housing appointments, linkage with SNAP, cell phones or landlines, dental care, outpatient STD treatment, referrals to inpatient treatment, MAC clinic, prescriptions, and safer injection or harm reduction education, food pantries, clothing pantries, peer recovery coach referrals, and mental health referrals. So that's.
Yes. So it's a lot to speak of, but we are doing our best with limited resources to provide all those wraparound services. And we cannot stress enough how important it is to have resources for housing and for recovery and MAT programs. And so we are trying to develop those linkages and being able to, when we're out about in the community, being able to offer a place for those individuals to go when we engage with them. So that's really kind of the bulk of our activities. Kind of some updates. We are in the process of trying to obtain additional SOAR funding through a different grant to purchase a larger, fully functional mobile medical unit. That is in process. Unfortunately, the lead times for building has been extended to now 12 to 14 months. So it will probably be, but it won't be before the end of next year before we actually see this unit. But we're doing the best we can with our cargo van that we have, and so we're out in the community doing that. And then we also have some open positions. We have a community health worker position, a peer recovery coach position, as well as a part-time pantry clerk. And these positions have been open for several months now, and we just haven't had much headway in getting applicants for that. So if you know of anybody that might be interested in helping us, there's definitely a need there. And then finally, we have 2 full-time individuals that have been hired for the Ryan White program that are available and hopefully will be helping to integrate HIV testing in the emergency departments at the hospital, trying to integrate testing as much as possible within the normal flow of work and development of standardized protocols for that HIV testing. And with us to be able to be there to provide a warm handoff to linkage to care resources, as well as prevention resources like PrEP and syringe services programs. We're kind of in the middle of a COVID crisis right now in the hospital setting due to being short-staffed. So things have been kind of put on the back burner, but we've got the resources and we want to make some headway, and hopefully next year we can do that. That's really all that I have at this point. And I appreciate your interest.
Thanks for that update, Christine. That was awesome. Any questions for Christine and her team? All right. I'm gonna move along to Angie. I see we've got Angie and Rhonda both here from HealthRight.
Can you hear me?
I sure can.
If I got Rhonda here with me. So I'm just going to go over the last quarter, and then Rhonda can chime in. For September, I'll just go September, October, November. September, we did 109 Hep C tests, 116 HIV tests. 5 were positive and transported to Ryan White, but only 2 were new. In October, we did 162 Hep C tests, 203 HIV tests, 2 positives that were new that we got in with Ryan White the same day. We also have COVID vaccines and Narcan dispensed and flu vaccines, but you guys don't want to hear all that. For November, it was 119 Hep C tests and 134 HIV tests. 2 were positives, but they were old positives that we got them reestablished with Ryan White. So in our efforts, September through November, 4 new were identified. And we still have the mobile medical street medicine unit out, still doing PrEP, still getting people on, tested and starting those that we need to on HIV meds and doing all the stuff. Chime in, Rhonda.
I think I'm going to chime in because I'm going to go to the syringe part. We are one that actually got licensed. So we officially have our license. So, and I should say that I worked extremely hard on that. So
yes, she did. Yes,
Great
she
news.
did. Yeah, so we're licensed for both locations.
Yep, main clinic and Covenant House.
Covenant.
But I do think it's important. I mean, we're doing STI testing as well on our mobile unit. It's made a huge change with us being out there. But I know a lot of people, but I know Dr. Young understands this. It's really hard to get people to get a COVID vaccine or a flu vaccine. And we kind of talk about it when we're doing the HIV testing and the Hep C testing. So I think it's important to know in 2 months' time that we did 99 flu vaccines out on outreach. That I don't think would have happened had we not been on outreach with our homeless population. And we also gave out 58 COVID vaccines to our homeless population while we were out. It's developing the trust, as you all well know, to get that done and protect our community.
Well, thank you, ladies, for the update. And I have to give you guys a personal shout out. After several attempts, it was HealthRight that was able to get my son fully vaccinated, who's 6 years old. It was your nurses who was able to convince him to get vaccinated. So thank you guys
Wonderful.
so much.
Right. We have some great nurses here, and Isaiah is like one of the best. That
yes, he is.
Do anything.
He's amazing.
It's amazing. Thank you.
So, and I see Dr. Amajad joined us this afternoon. I know she was coming late from a briefing and some calls at the GADF, so I just wanted to give her a chance to say hello this afternoon to folks.
Thanks, Shannon. Sorry I'm late, guys, but I just wanted to say thanks to everyone for all the hard work they've done. I know a lot has been done at the homeless shelters and other mobile events, but you guys have done a really, really impressive job these last few months. And anything we can do to support you, please let us know. I know Sherry keeps in touch a lot, Angie, with the stuff that's going on. So it's really impressive what you guys are doing. It's really making a big difference. I can't thank you enough for that. But and I hope you have a good Christmas if we don't see each other before then. Thanks, Shannon.
Thank you. All right. Does anyone else want to speak up now in terms of partner updates? Thought I saw Cassie on the phone.
Hello, yes, I'm here. So a little update from the Covenant House in Hopwa. And I'm too just going to do on the last quarter since September here. We've permanently housed 15 different individuals with HIV or AIDS, and we are currently paying monthly rent for 19 individuals, of course, with HIV and AIDS. It's not all in Kanawha County, this one. I got a couple in Raleigh County because I do 22 counties here in West Virginia. So we also put in for a big competitive grant with the state and some Cabell County partners, Harmony House, and we actually got denied for that grant. So it was a big hit on us. It was going to help us a lot with our outbreak. So partnering up with Lee Tabor to try to come up with some new ways to get some more funds. I don't know if you know how the Hopwa is done, but you get one big fund for the state and then they break it down into all the little Hopwa stuff. So with 22 counties, I have the most counties out of the 3 different people who do Hopwa, and we just don't get enough money. So we know that housing these people is a big step in getting them in care and to stay in care and to keep them healthy. So we are out here, boots on the ground, really trying to make this work. We're going to be on a tight budget without that grant. Other than that, the 15 people that we help monthly right now are set and good, and we're just going to be looking for different ways to get more. I know we work closely with 32 of the individuals that's been diagnosed since 2019 with all of them, but the 24 that are unhoused. So it's we still see them pretty much weekly at least. And work real close with Brooke Parker with doing that. That's really about it. That grant really kind of put us down. So my stuff is.
Where does that funding come from? Sorry.
That was a competitive grant from HUD. So
Okay.
and it's a little awkward when you read who actually got the grants, who actually got the competitive grant. That was the maximum amount was supposed to be 2.4 million, and then there's some states that got 5.5. So Lee himself said that he was going to. Lee Tabor said that he was going to complain about it because, I mean, we have the highest rates. So not getting it, we want to know why we didn't get it. Just brainstorming together and with the other partners who tried to get this grant, we think it might be because the lack of and the harder to get needle exchange programs. The states who got it all have very well running programs, so it's with less restriction. So that I think that is a big thing. HUD just came out with new strategies for HIV for 2001 till 2005, or sorry, 2021 until 2025. And the number one thing on that is needle exchange programs and working in compliance with them. So we're just trying to figure out where we went wrong, and we will apply for it again, but just took a big hurt on us there because that was going to fund our transportation to MAT programs for our people. That was going to fund hopefully transitional living style type of housing so we could get them. It's very hard to get people from homeless to stably housed very fast. So, but to get them comfortable and get them on meds and to get them on psych meds and to get them going to the doctors and doing everything they need to do, I just need a place to put them to find them. So it's a little hard, but we're working it. But I'm very excited for the 19 people that we have helped just in the last few to get permanent housing. Some of these people have been living with HIV and AIDS for a long time, but most of them are newly diagnosed since 2019. So just working with Brooke a whole lot and working with Health Right a whole lot every day, and that's what we do. Oh, I don't know what happened.
Thanks, Cassie. Lee, you got your hand raised?
Yeah, can you hear me okay? I so rarely use that button, but it seems like and Cassie, I'm so sorry to hear about that. So thanks for sharing with the group. I'm a little new to this group. For folks who don't know me, I'm Lee Storo. I'm with Community Education Group. Y'all probably seen Amanda Morgan representing our policy team in the past. I just thought I'd give a quick plug since there's so many folks gathered that we did launch the Appalachian Partnership Fund as an organization a couple weeks ago. CEG entered into a collaborative agreement with the CDC to distribute a little bit more than $1 million to West Virginia nonprofits who are doing any work around COVID and having that intersect with HIV, viral hepatitis, substance use, and that broader syndemic. Many of y'all have heard me give this pitch before, but for folks who may have not heard about it, welcome your help in getting the news out to folks in West Virginia. We are new to being an intermediary funder, but also wanted to extend the invite for folks to apply yourself. Applications are due January 10th. We are very open to having conversations. If you want to reach out to us, if you want to share, if you want to brainstorm an idea, if you've worked with Amanda before or can reach out to me. And I know many of you have worked with Tony Young, RED in the past. So I'm dropping the link in the chat to the application, and I'll drop my email as well.
And another bit of info from CEG too. We also are launching a substance use disorder stigma reduction training series in January. And it does have some information on how helping to treat the intersect of HIV patients who have substance use disorder as well. So I put the flyer in the chat and I'll have a link to the registration for that. So that'll be Tuesdays in January from 10 to 1 p.m.
Thanks for that, Lee and Amanda. Others have updates for the group? All right, well, I'm going to throw out a question to the group. We didn't get a chance to meet last month, but how do you guys feel about the cadence of every other month? I felt like this meeting was really fruitful in terms of the updates folks were providing instead of monthly, but that is just one little opinion. And so I'm interested in others folks' opinion, which would have us meeting in February. What do others feel? If not, we can continue the monthly updates, which would have us meeting the second week in January following the holidays. And if nobody speaks up, I'll just make the executive decision because that's just how I do things.
Thank you, Shannon. Last February, the CDC remarked that Kanawha County was home to the most concerning HIV outbreak in the nation. I'd be thrilled if we had weekly, if not daily meetings, but monthly, I think would go a long way to help us keep up the momentum and having them sort of really locked in, because when they get shifted or changed, I think it threatens the momentum that we do have.
Okay, I appreciate that feedback. Well, I definitely don't think this is the only meeting where folks are meeting, but this is definitely a public-facing meeting where folks can do public-facing updates. We do invite the media, but I can definitely respect that opinion, and I appreciate that feedback. Do others have input? And Joe, you know, if no others speak up, you're the winning vote, because that's how we
You
roll
have a
around
vote
here.
too, Shannon. You have a vote too.
But I'm a public servant, so.
Are we all?
Well, I will comment that it does make it hard to actually do the work and do all the testing and be out there actually doing what's needed to be done if you're meeting all the time. I don't think it really matters between a month to 2 months. We'll be there regardless, but there is a certain amount of time that we really need to be doing the work and not just talking about it. My 2 cents.
Yeah, that's kind of where I come from. And I am a little concerned with the holidays between now and the beginning of January, how much updates and work is actually going to be done other than just some general testing events.
And then you have COVID, and then you have flu, and then you have all the other issues that you have for most groups. I mean, by all means, very relevant, so important issue. But
absolutely, honey.
You know, the majority of us can't exclusively just focus on this exclusively. But we're more than happy, like I said, you know, if I'm on it and Rhonda's on it, that might be a day that we don't do a certain outreach or whatever, but we're here to do the work, whatever that needs to be.
A couple of hand raises. Hunter.
Hi, yeah, just as like a member of the public who isn't in other meetings and who has a vested interest in, you know, I definitely prefer monthly because otherwise I'm not able to hear anything. And yeah, I don't think an hour out of a month is stopping folks whose, you know, feet are actually on the ground in this work.
All right, I appreciate it. I thought there was another hand raised. It disappeared. Well, I think the majority rules, and we'll continue with monthly reports. And so we'll go ahead and get the January meeting date posted. Any other questions or updates from the group? Oh, there it is, Chad.
Shannon, I know there's a lot of people reporting and having to do the boots on the ground work, that if we could kind of bolster each other, like report for each other to help get the word out there, to have the public facing side for the every month, but not put the responsibility on those to have to be on the calls every other month. We could certainly try to help bolster that.
Great idea. Did you have something that you wanted to ask?
Yeah.
Okay.
Can you all hear me okay?
Yes.
Great. I wanted to jump in with a question. I listened to the last task force meeting and harm reduction wasn't mentioned. So I was really glad to see SSPs on the agenda today. Because of course, the first recommendation in the CDC's Kanawha County EpiAid states that we need to expand access to sterile syringe and other injection equipment through a comprehensive harm reduction service, such as low barrier one-stop shop models in multiple locations that also incorporate mobile and street outreach elements. So my question is, what are the Kanawha Charleston Health Department's plans to establish and expand comprehensive low barrier harm reduction services at service points across the county in order to fulfill this recommendation?
Yes, so this was a new question that was brought up. And well, not a new question to the Kanawha Charleston Health Department, but new discussion for the topic at hand today. That is not only a decision of the board, but that's also a decision thanks to the legislation that was passed last year. There are a lot of barriers and issues that we would have to present. So in the manner that you asked the question, there are no plans to implement that at this time.
Let me add to that really quick, Sherry. I know West Virginia Health Right did apply for the SSP program, and they were approved at their main clinic and at the Covenant House. I don't know if Andy's still on, but so Kanawha County does have some access. It's not that there's no access to syringe exchange programs or service programs in Kanawha County. West Virginia Health Right is offering them.
It's a fairly high barrier program though, compared to what the CDC recommends. And of course, what the decades of research recommends as far as really getting a handle on HIV and also dealing with the other associated issues like endocarditis and other things that go along with intravenous drug use.
It is also following our legislative rule, so we have to
There
abide by
are
state rules.
also city rules and ordinances as well that you have to follow in addition to the legislature for Charleston.
Stacy, you have your hand raised.
Hi, thanks. This question is either for you, Shannon, or Dr. Young. Who are the outside experts that the facilitators of the HIV task force are engaging in order to determine the scope and the depth of a Kanawha Charleston Health Department future comprehensive harm reduction program? For example, have we reconnected with the authors of the CDC EpiAid to help us set a blueprint for comprehensive low barrier program that could meet all of Kanawha County residents in the towns where they live? Or would we be asking West Virginia harm reduction experts like WVU's Dr. Robin Pellini to present to the task force?
I think part of your question was answered in the previous question addressed by Dr. Young. I don't know if there's anything else further to add with that. We do have to abide by our current state and local laws, and we are addressing the recommendations in the EpiAid within the scope of our current laws. Hunter?
Yes, thank you. I'm gonna apologize in advance for this question, but I just as a concerned citizen and you know, someone who volunteers in the field, I've worked with houseless folks. I, like so many people in West Virginia, have loved ones who struggle with addiction or in recovery, what have you. I've lost people. What is Stop It? You all work in this and you see how these laws have harmed these efforts, and now funding's being lost and people aren't receiving the help that they could receive. Why aren't people being louder as individuals? I understand as organizations, you might have your hands tied in what you can do or say politically, but as individuals, to change these harmful laws and ordinances that are harming our community. And I understand that folks might not have an answer for this right now, and I apologize. I am trying to say something. Yes, this can't, solving this epidemic can't fall on one clinic that can't help everybody. And I wish folks would be louder in making the changes we need to make.
So I think this small group that you have on this phone right now is very passionate about the work that they're doing. But we need more community partners to step up and do more work in the community. It's gonna be all hands-on approach. You're right, not one community group can do this. And we as stakeholders, state agencies, we have to abide with the current laws that are passed by our legislature. So there's lots that can be done with our current laws and regulations that are currently in place. And we all need to come together to be creative and work outside of the box to work within our current laws and legislation.
But my question is, at least as individuals, why not be loud about fighting to change these laws that are making this work impossible to do thoroughly?
As a state employee, like, we don't have, that's not within the scope of an
Even as
individual that we can do.
individuals?
No, we're state employees.
I spoke my political opinions as a state employee. I worked for an elected Republican.
This is not the place for political comments or legislative law. If there's something else we need to discuss, but we can't argue back and forth what's already put into law in the state and that's already been done. This group is here to be as effective as possible and use what we have within our scope of practice and our ability to be creative and address a situation that's been ongoing. So if there's anyone else, I'm not going to argue on this call.
I was going to hold this question. It's just a quick question. My name is Alicia Allen. For those that don't know me, I'm an LPC, and we have a newly licensed behavioral health center on Courier Street. It's a group practice. And I've worked with some of these folks quite a bit that are here today. So I just had a quick question. I noticed about 50% of the individuals that have been, there was a statistic that was listed earlier, and there was around 50% of people that have gone through testing, I think reported positive testing, that are unstably housed. And so I just wanted to ask about a report out around Shelter Plus Care housing in particular. It's a permanent supportive care housing program. And the reason I ask is because I've had a history of sort of performing some street outreach, but also I'm continuing that on our office sites where we're doing some assessment work to help fill those vouchers, and then working with any groups that are interested to help fill the gap in providing the plus care services to keep those folks housed and linked to care. So I wanted to ask about if anyone in this group is kind of staying abreast of the utilization of those permanent supportive housing programs that might directly impact those numbers. And then also, if there's any other, I was trying to look around, if there's any other behavioral health providers that might, one of the things that I know I do particularly in this practice and some other folks, we work directly with some of the recovery communities. And then outside of that, obviously we do just the basic psychosocial assessments and some other screening at intake. So we are identifying some of those risk factors and trying to help link folks into care and create opportunities for testing, or inform folks about existing opportunities for testing. So I just didn't know if there were any other, I didn't know if there was any kind of work committees or any other behavioral health providers that are on this group. I kind of heard Dr. Young talk earlier about maybe, some of the integrative behavioral health pieces, and also maybe breaking down the group so all of the providers aren't committed to monthly meetings if people are having a hard time doing the work and keeping everybody updated. I understand the duty to both, but I understand time constraints too. So I just wanted to know if there were any other behavioral health providers here engaged, and if anybody's kind of keeping track, or if there's any report outs of what's happening around shelter plus care. And just really quickly, I know the last that I was aware, compared to Cabell County, we're only Highbrook and Ryan White and everybody that I haven't seen in a while. Hi guys. But we in Charleston, I think utilize maybe 30 some vouchers. And if you look at like our close neighbors at Cabell, it's over 200 and so or so. And there's some issues with service barriers and keeping those folks maintained in housing. So I just wanted to know if anybody's keeping track of those utilization rates or how those numbers are trending, because I believe they directly impact what we're looking at. I know that was lengthy. Did anybody get any question? Does anybody, you guys understand what I'm asking?
Hi, Alicia, this is Suzanne. I can tell you that that particular metric comes from, it's just sort of a standard risk investigation question that's done during a case interview. And it just specifically is the question of, have you been homeless or unstably housed within the last 12 months? So from the surveillance team and the surveillance perspective, that's the only metric that we measure. I'm not sure if any of the other service providers have any additional information on these, on the service plus or the shelter plus vouchers that you're talking about, but we don't.
Okay, I heard Cassie talk about Hopwood, and it just brought to mind, I wonder if anybody's kind of paying attention to the numbers that might directly impact this population. So.
And Alicia, we talked about this before, but just so everyone else knows, this is Cassie again. Most of our unhoused population go through a homeless, SPDAT is what it's called, and they get scored on and their scores tells us where they should fall in our housing categories. Shelter plus care is one of the top for the people that are living with HIV and AIDS, because they have had so many ER visits. They've been homeless for so long. They've been, they have nowhere to keep meds, nowhere to do this, nowhere to do that. The score always ends up being either housing first or shelter plus care. Right now, I have one client in shelter plus care when I really probably have 30 that qualify for that program. It's just getting them in that program is harder. And when they score that high, that means someone like the HOPWA that we provide in the case management isn't enough for that individual to stay stably housed. When they score that high and they get the shelter plus care, it's because they need the plus care part. Plus care being a case manager in there almost daily, but at least weekly, giving them, weekly goals and this and that. That's just something that HOPWA itself can't do because we're spread so thin and we have so little resources. But with the shelter plus care, if we could find a partnership with someone who could do it, especially for the HIV homeless population that we have right now, it would help tremendously, because they would get rides to the MAC clinic. They would get rides to the doctors. They could learn how to fill their prescriptions and keep them filled and get them on time. And this is stuff that takes hours and hours and hours that one case manager for 22 counties can't do. So this is why it's very important to utilize these vouchers and not send them back to the housing people, which that's what's happening right now. They sent numerous vouchers back that they weren't used. And it's the process of actually getting one and getting it started and getting a provider to do the plus care part.
I'm right there with you, Cassie. Just so you guys know, we are a nonprofit and to some degree free and charitable. So we do have some grant services that help provide. They help us be able to provide assessments, even if they're non-billable. So with the application piece, like I said, we do have we have around 6 clinicians, and I just got 2 more coming on. So we've got folks that we can get them in pretty quickly for that piece. And I'm more than willing to build out some of the case management stuff. I know there are some individual providers that have been kind of testing that out to see how they can be reimbursed through case management for that kind of outreach style work. So I know there are some folks kind of working toward that. I didn't see them here today. And I know just in Charleston in particular, just historically, I think Prestera has kind of helped with that plus care piece. And then outside of that, it's been groups that are really, very, very helpful. Like I know the Kanawha Valley Collective, and I think years ago, maybe even Rourke Sullivan, but there's no opportunities for reimbursement. So there might be some a space there to kind of couple some targeted case management with some of the grant funded service providers in order to get that daily plus care piece rolling and better utilize those programs and services so that Charleston can start to retain the vouchers that we do have and start to request more. For a really long time, we have not been able to fill those permanent supportive housing spaces. And I think, like I said, that's directly impacting what you see in terms of our homeless trends each year. And I think impacting kind of folks' opportunity for testing and how they stay in care, some continuity there. So that's my piece. That was my question. Thanks, Cassie. And, for me or any, opportunities to work on the things, I'm around.
Thank you for that. We'll go to Corey next. I know you've had your hand up for a while. Sorry.
No worries. Thank you, Shannon. My question, and I apologize if this isn't really, because it kind of overlaps with what Hunter was asking, really. And I recognize that all or most of you are not lawmakers or anything, but seeing as there's so much restrictions on these programs and funding too, and that the state isn't even getting funding, I've had a lot of conversations with different either people in city council or people, in the legislature, and it just doesn't seem to be understood what these new restrictions are doing. And I wonder what is actually being done as far as advocacy. And, has there been any talks with the West Virginia Center on Budget and Policy or any other lawmakers to kind of persuade and get them to understand the position that everyone's in, and that it's really difficult to get out of, an HIV outbreak when we're piling on restriction after restriction. And so I'm not seeing much shift in anyone who has the power to change these laws, there's not really been much of a shift so far in them understanding the impacts. And I'm just curious what is being done as far as advocacy for this, and what's going to happen in the next legislative session next month.
I could maybe answer that as someone who works in the policy advocacy world, is that there are groups that are trying to work with the legislature to change the narrative. Right now, there's a closed-mindedness about making any changes in the law, but there are groups that are out there that are working toward changing the narrative around, basically saying that yes, there continues to be HIV outbreak. There continues to be a need. And so we're really trying to re-engage them in a way that doesn't put them on the defense. Because right now they are on the defensive about it. And we are just trying to be educational rather than confrontive. Granted, what you're saying is correct, but we're trying not to engage them in another controversial situation that will only make matters worse, as far as some of us who are in that space right now.
When you say make matters worse, do you mean, I'm not sure what that means.
No, as far as matters worse in a sense that they dig their heels in the ground more deeply and not respond to us at all.
Gotcha. Yeah.
We're trying to provide facts and reality rather than, if you want to call it motivational interviewing process, that's kind of where a lot of us are, that some of us at least that are in that advocacy realm.
Great. Okay. I would like to talk to you more about that later.
Sure.
Thank you.
Amy, you've got a question?
Yeah, Shannon, I'm not sure if you received the email or not, but I have a couple questions on behalf of Commissioner Carper. Can you hear me okay?
I do, and I've got written responses to send to you after the meeting.
Oh, okay, that'll be perfect. Thanks so much.
You're welcome. Matt?
Hi. For anyone who doesn't know, I'm with WSAZ, and I have a few questions that I wanted to ask. Only thing that I did want to say before I start asking questions for whoever does want to answer, if they could actually say and spell their names for me, and also just say their title. I know this is being recorded by us, and also I know y'all are going to be putting it on YouTube, but I just want to make sure that when we're putting this on air, we don't have anyone's name or title, incorrectly. Just to start things off, I want to start a little broad. There's obviously been a lot of info to share during this meeting, but when we're sharing the story, what do people watching need to understand about the state of HIV here in Kanawha County?
Hey, Matt, did we get your request to do an on-camera interview after this?
I had emailed Andrea. She, let's see. She asked me if I could submit questions. I mean, it was in regards to, I didn't know what questions I was going to ask at the time. Obviously, I've been sitting through this meeting, but that's where I'd like to start. I'm still more than happy to do a one-on-one interview. I just never got the okay if that would be okay.
Can you submit your questions and we can do that? I've got a 1:30 I've got to prepare for, and we're running short on time, and that way we've got a little bit more time together and we can pull up the slides if you want to do a more in-depth interview. Does that work?
Yeah, that works. We're trying to run something at 6 to 9. I know you just said you had the 1:30.
I'm free after that.
I was going to say, because I have another Zoom meeting, another task force thing that I need to be in at 3 to watch. So if we could do something like 2:15, I could do that.
That works.
Great.
Just really quickly, Katie has a quick question as well.
No
She just sent
problem.
me a message.
Remember, I still have a question as well, if that's okay.
I'll let Joe go. That's okay.
Thank you, Katie. I just wanted to share, I think Dr. Amjad is still on the call. Dr. Amjad, like, you're one of my heroes for the work that you did in 2015, starting a small harm reduction program in Beckley. I mean, that's a role model for so many scrappy harm reduction around the state. My question is less for you, but connects to another quote from Dr. Young from May 2019, where Dr. Young, the county health officer, told WCHS that if we do see a disease progression into our community, being high rates of HIV or other things, we may have to have the discussion again. And this was in reference to rebuilding harm reduction in Kanawha County from our health department. And at this moment in time, in December 2021, Kanawha County leads the state in new HIV cases and overdose deaths as well. And this is all since we shut down our harm reduction program, our accessible one via our health department in 2018. We mentioned this before, the CDC noted under a year ago that our county carries the most concerning HIV outbreak in the whole country. So my question is, if we haven't already hit a tipping point for our health department to act, to build low threshold accessible harm reduction programs around the county, are there higher disease metrics or fatality metrics that we need to reach before our health department can follow CDC recommendations to relaunch harm reduction efforts across the county?
Matt, this is Aina Amjad. I'm the state health officer if you need my name and things. To answer your question, Joe, there's no metrics or magic number. We're already at a critical point of HIV, not just in Kanawha County, but also hepatitis C in the state. And to answer you simply, as I've said before, there's not just one way to address a problem. We're looking at things from a comprehensive clinical view, which has also been provided by the CDC. Yes, syringe service programs help, but they are not a unicorn in the field. We have to use everything in our toolkit, everything that's allowed to us by state rule at this time, and we continue to move forward. But no, we're not looking for some magic worst number. To say that to me is preposterous. So we are using what we can as healthcare providers under the state law. And I also know too, by running that clinic in 2015 that everyone likes to refer to, that is a comprehensive care model, because I was not handing out needles. I saw people in my MAC clinic, my primary care clinic, and followed them up religiously, which is what we need here. It's not simply handing out needles. So I do not believe in that as a sole fix to any problem. And with that, I'm sorry, I have to go. I have that 1:30 meeting too. And if someone needs me, they can email me, but we need a comprehensive care model that has a lot of facets to it.
Thank you, Dr.
And that is from my experience.
Thank you. All
right.
I appreciate
Thanks.
that you did in 2017.
Hey, Dr. Amjad, before you
wanna
leave, I'm
clarify-
sorry. Can I get my question in really quick? I'm sorry.
I did want to
Katie.
clarify that question was for Dr. Young, for when our Board of Health and our county health officer will start to act to rebuild harm reduction in a wraparound way, as recommended by the CDC in their first recommendation in the new year.
We are having that discussion. We have that legislation. We do have those recommendations, and we have to look at it as a county. This is something that has been addressed by Health Right. They've done the programs, and as far as opening up a low barrier, what would be defined as a low barrier harm reduction program is against the state guidelines.
It is not against the state guidelines that and
legislation.
It's hampered by state guidelines, but health departments across the state, as we heard from OFLAC earlier, are relaunching and launching programs. Why can't our health department be a leader as well?
That is a discussion for the board, and that would go before the city and the city council as well as the county commission.
Will you be championing that with the board?
As far as the harm reduction program, I think we get plenty of service with Health Right, and I agree with Dr. Amjad that yes, we do a lot of different services wrapped around together. As far as doing a low barrier harm reduction program, it would have to be something that fits the needs of the community.
One last question before we sign off, Katie.
Hi, really quick, Dr. Amjad. I know that you have to get off here, same with Shannon. Based on what you've heard today and what's been unfolding for the last few months, would you say that SB 334 is directly complicating our response to HIV in this state?
I can't say that because, like I've said before, from my experience with any syringe program, I've always encompassed all care with that. So while it might seem stringent to some people, I do not disagree with it, that you need to offer people everything. And it's up to the place that wants to do it to offer all those services. I'm all for comprehensive care, follow-up care, and so on. I do not believe in a magic bullet, a magic syringe, or anything. So no, I'm not in disagreement with it. And I'll always follow the rules, even when they had MAC clinics open, anything open that's new, I will follow the rules to take care of patients and do the best I can what I have in my hand at the time. I do not argue with rules or laws made up by anybody. So I will do what I can for a patient under the constraints that I have.
Okay, and when you say you're not in disagreement, you mean not in disagreement with SB 334, right?
No, because that was already passed. And
I just
all it,
wanted to make
to
sure-
me,
I just
says
wanted
we
to make
want
sure I understood.
comprehensive care.
And then I had a few clarifying questions really quickly when, I don't know if they're still on here, but when we were talking about the syringe service programs before and the 9 that have been approved through OFLAC, do we know how many of those programs were operating at a needs-based level before and have added a barrier to meet the needs for OFLAC certification here?
I don't think Jolynn is on anymore, and either is Elizabeth, who can
email.
answer those questions. So I would email them if you need clarifying questions
email.
answered.
Okay. And then one last, if Cassie's still on here, I missed the name of the grant that she said that they missed out on, if anyone had that, even if it's not Cassie, if anyone just heard it.
I know it was a HUD grant.
Yeah, competitive HUD grant. I didn't get which.
That's all it was, the competitive grant. It didn't have like another name.
Okay, I just wanted to double check with you. Thank you very much. That's all I have for today. I know you'll have to get off of here.
All right, sorry to cut everyone off. We have to jump to a 1:30 meeting. Thank you guys all for joining this afternoon. Hope you all have a happy holiday, and we'll touch base at the beginning of the new year. Talk to you later.
Thank you.
Thanks, Shannon.